Okay, Vicky, whenever you're ready, we're excited to learn about H. pylori.
Great. Hi. Sorry, everyone. I have very unstable internet, is what Zoom keeps telling me. So I apologize if I cut in and out or speed up, slow down because of my internet. But hopefully, we'll get through this presentation about H. pylori. Um, These are our objectives today, which are to discuss H. pylori infection risk factors and epidemiology, incorporating an equity lens, apply H. pylori pathophysiology to visually identify disease manifestations on some EGD images, differentiate H. pylori diagnostic methods and select the most appropriate in a case-based example, and apply appropriate therapeutic and follow-up strategies after H. pylori diagnosis. And I guess my disclaimer, I don't have any disclosures, but my disclaimer is I am not a gastroenterologist. And so I am not an expert on this topic. If you have any updated information or some corrections, I welcome any feedback because I'm still learning about H. pylori as well. So we're going to follow a clinic patient today. So you're seeing a 32-year-old woman with no known past medical history who presents with 3 months of progressive epigastric abdominal pain. She has no known allergies. She's taking omeprazole. She's tried famotidine and Tums, but nothing is really working. And so, you might have a guess about what this case is going to be because this is my presentation. But I want us to use this case as a kind of stepping stone to think about what some risk factors for H. pylori infection may be. And if you want to pop some in the chat, I can try to look at them. Risk factors for H. pylori infection. Yep, geographic location is probably the biggest one. And so this patient was born and raised in Southeast Asia and immigrated with her family to the US 7 years ago. Epidemiologically, H. pylori is one of the most common chronic bacterial infections worldwide, and some studies estimate that the prevalence is about 50% of the world's population. And some areas are more endemic than others. So this is a graph showing darker shades of red is more prevalence. In the US, it usually averages around 25 to 40% prevalence. But in some geographic locations, it's as high as 80 to 90% of the population with H. pylori infection. Transmission-wise, it's thought to be mostly person-to-person or fecal-oral exposure. Contaminated water is one of the biggest sources, and some studies that test H. pylori in well water or public water sources show like 80 to 90% prevalence. So that's kind of how we get some of that data. And interestingly, short-term travelers are unlikely to contract H. pylori. So this suggests that there are other factors besides just transmission. It's not like, your ETEC or other bacterial GI infections. There's some other kind of chronic processes going on. And we are a very equity lens based residency. And so I think Tony kind of hit the nail on the head about really thinking about risk factors as geographic location and, amount of time you spend in endemic areas and not so much about other ethnicity or race-based factors. Income can be SES can be, but kind of thinking globally, much of the world's population are in more impoverished areas that usually will have less clean water and more endemic H. pylori. So some things to think about when you are thinking about when you would suspect H. pylori in one of your patients. Okay. So you find out that she was born in a rural town with endemic H. pylori, and she drank well water a lot. She has no family history of H. pylori infection. She doesn't really know what it is. And no one in her family has ever had similar symptoms before. And so I think one of my questions was, well, if 80 to 90% prevalence of H. pylori, why do some people have symptoms and others don't? And so I looked into some of the pathophysiology about H. pylori because I think we have some misconceptions usually about what H. pylori can do in the body. So H. pylori is spiral shaped, it's gram negative, but really there are kind of 4 characteristics that I want you to remember. Number 1 is it is motile. It's got little flagellae that can help it swim through the mucus layer of the stomach. It's urease positive, meaning it can turn urea into ammonia, which neutralizes gastric acid. And so that's how it survives in the stomach better, by neutralizing its surroundings. It can adhere to the epithelial cells in the stomach, so it kind of gets stuck there. And then all of this together, it produces all of these proteases that can cause chronic inflammation in the stomach. This chronic inflammation leads your stomach to be less good at its job. And so the mucus layer gets damaged and you can have just this chronic inflammation picture. So kind of the main takeaway is H. pylori can directly and indirectly damage cells in the stomach, both by the bacteria itself kind of putting out proteases and other enzymes, and then your stomach kind of being damaged by kind of self-producing acid on a very inflamed stomach already. Kind of a review of normal acid production as a way to think about, as a way to segue into how H. pylori can disrupt these mechanisms. So your stomach is split up into different parts. The antrum has G cells, which make gastrin. It's easy to remember. These G cells, through ECL cells and histamine production, really they stimulate parietal cells to make acid. And then the acid downregulates G cells from making gastrin, and you have this nice, like, well-regulated system. The body is smart though, and so there's 2 off switches. So acid also induces D cells to make somatostatin, and somatostatin is made in both the antrum and the body of the stomach. And somatostatin is an off switch, so it downregulates G cells and parietal cells, so you can decrease acid production once you've made enough. So gastrin's your on switch, somatostatin and acid are your off switches. So what does H. pylori do? So when it's in the antrum, it causes inflammation. So it takes out your D cells and your somatostatin kind of more selectively than the G cells itself. Actually, the lack of the downregulation of the G cells gives you an increase in gastrin, which, increases your parietal cells' acid production. And so you can have inflammation because of acid hypersecretion, meaning your parietal cells are making too much acid. H. pylori can also present as this pangastritis, meaning it affects more than just the antrum, it affects the body of the stomach as well. What happens here? You've got inflammation all over. You've got your D cells and somatostatin are out, your gastrin is upregulated, your parietal cells make more acid. That all makes sense. But when you have this acid, in conjunction with the inflammation in the body of the stomach caused by the H. pylori, over time, this kind of takes out your parietal cells. And so kind of this longer term effect is you decrease your acid production because you take out the parietal cells, because they're more susceptible to damage because inflammation of H. pylori itself. Does that make sense to people? Does that make sense the way I described that? I hope so, because basically the main takeaway is H. pylori can present as different phenotypes depending on where it is kind of made its home. And antral type gastritis, it can cause increased acid production, and in pangastritis, you can have decreased acid production. And this is probably one of the reasons why not everyone with H. pylori has this like typical dyspepsia picture. And really there's a range of presentations of H. pylori infection. So it can cause both acid, hyper, and hyposecretion. Okay. We're going to take a little magic school bus ride through an EGD. We're going to look at some EGD pictures of some of the presentations of H. pylori or manifestations of disease. So this is supposed to be an interactive part. You can interact via chat, but you can also interact in your head at home. So we're going to start from the E part of the EGD, and we'll make our way down. So anyone have a guess at what this might be? Yeah, so this is the esophagus. It is the lower esophageal sphincter, the GE junction. So this is GERD, and kind of the thing to look at here is this kind of reddish part is extending a lot higher than where you would expect just at the GE junction, and this is just inflammation in the esophagus. So the increased stomach acid secretion can cause inflammation of the esophagus, kind of self-explanatory. This is a different part of the GI system. Anyone have a guess where this is? What part, what, just anatomically, we'll start there. It is the pyloric sphincter. So you're looking down from kind of the body of the stomach to the pyloric sphincter, kind of this little dimpled part. And kind of as McKenna is pointing out, all of this redness is inflammation. So this is what gastritis can sometimes look like. It doesn't always look like this, but this is probably a pretty severe and I think visually interesting picture of gastritis. Sometimes it's just kind of more pinkish or actually more pale from the inflammation itself. So it's not kind of a healthy pink tissue. It can sometimes just look more red or more white, depending on what stage of gastritis it's in. But in any case, H. pylori can cause acute gastritis just from the inflammation. Self-explanatory. This has an arrow sign. It's not a radiograph, but it's got a similar. So this is the same part of this. This is the stomach still, I should say. It's not a peptic ulcer. It's kind of has a little bit of, yeah, it's polypoid. So this is, and you can actually see the stomach here all kind of looks polypoid, which is a little bit of a clue. But this is a gastric adenocarcinoma. So it kind of, in this case, is like a polyp that probably they've got some risk factors, some metaplasia already in the stomach, and this one is probably a dysplastic polyp. 36 to 47% of all gastric cancers are attributable to H. pylori. It's a really high number, but only a minority of those with H. pylori infection will develop gastric cancer. And actually, when you are diagnosed with gastric cancer, they will always test for H. pylori just to see if they can decrease any further risk factors of development by treating the H. pylori infection. Okay. This looks like it would be in a different place, but this is also still the stomach. You're looking at kind of around the cardia of the stomach, so like the bend. And so that's what this little flap is. The pylorus is kind of behind there. This is a maltoma or a gastric lymphoma. You just see kind of this dysplastic looking stuff all over. And so H. pylori, because of this chronic inflammation, leads to aggregation of CD4 lymphocytes in the stomach, and that over time can turn into lymphoma. And then lastly, this is a peptic ulcer. So it's kind of this whitish ulceration. You can see kind of this loss of tissue with a little bit of inflammation around the edge. And that's really what you call like a clean-based ulcer, meaning you can really clearly see the demarcations around that ulcer. Oops. H. pylori is present in 85 to 90% of all peptic ulcers that are not related to NSAIDs. So back to our clinic patient, you get a bit more ROS and exam to kind of round out her presentation. So you find out that she's had a 10-pound weight loss for the last 3 months, some intermittent nausea, fevers, no fevers or chills, dysphagia, vomiting, melena, or changes in BMs. And on exam, really the most notable finding is some epigastric tenderness. She's got a soft, non-distended belly. So what do you want to order to test your hypothesis about what she might have? I don't know if we can do a poll, Nikki.
Let me try.
Yeah. If it doesn't work, we can also use the chat if people want to just type.
I think I did. I think I did it.
Perfect. Yes. What do you want to order? Your urea breath test, the stool antigen test. You want a GI referral. You want some H. pylori serologies, or you're going to up to date it.
Let's give it a few more seconds. Okay. Well, people are trickling in. I'll end the poll. Can you see those results, Vicky?
Great. Yes, I can. So a lot of people are going for stool antigen tests or urea breath tests, but a smattering of answers. So we will talk about all of the different types of tests. So these are kind of the big 5 that I think people, or four that people know a lot about, one that people don't know about. It's not very available, but and these are like really, really new tests, but really kind of how I like to categorize it is invasive testing or non-invasive testing, meaning are they going to get an EGD to get a biopsy, or are you going to test some other non-invasive way? So that begs the question of what are the indications for invasive testing? So really, it kind of boils down to whether or not you would probably get them an EGD regardless, because you're worried about not just H. pylori, but something else happening in the upper GI tract, or not. And so in active PUD or a history of PUD, peptic ulcer disease, the rationale for upper endoscopy is just to make sure that there's no it's not like looking at the size of peptic ulcer, which can kind of lead you to think about follow-up EGDs and testing. If there's any concern for cancer, you would need a biopsy anyway, and so you would probably go for an EGD. And then there's the classic alarm features. So we will talk further about alarm features. But if you feel like they probably seem like they don't have any indications for an upper endoscopy anyway, then you can go for a urea breath test or a stool antigen test. And so this generally are patients who are less than 60, people who sometimes prior to initiating chronic NSAIDs, people like to get H. pylori testing just to decrease the risk of bleeding or peptic ulcers developing. And then some instances of unexplained iron deficiency anemia without other features, you can consider getting just testing empirically for H. pylori. But frustratingly, unexplained iron deficiency anemia is also an alarm feature in some cases. And so other alarm features are unintentional weight loss, dysphagia, odynophagia, persistent vomiting, any masses or a family history of upper GI cancer. You would probably favor invasive testing in those instances. I can't tell. I think this iron deficiency anemia really depends on your suspicion for H. pylori or something upper GI being the cause. If you have kind of a high suspicion, it might be worth it just to get the EGD and have more of a definitive diagnosis. But otherwise, you could just get a stool urea antigen test as a less invasive way. So just a little bit about these invasive tests. Biopsy, histology, really slow to get results, unfortunately, but the reason why we like it is it's usually under the right circumstances can be sensitive and diagnostic, and it can also help diagnose other upper GI things. Sorry. Oh. The biopsy urease test is a new type of test that uses biopsy specimens but gives you results within an hour, 1 hour to 24 hours. And basically, you put the biopsy samples into a special reagent. And if there's H. pylori, it'll change the pH and change the color. And this is a very sensitive and very specific test. But it's not available at a lot of different centers yet because it's a pretty specialized test. And so I don't actually know if UW, do patients need to also be off of PPI for the biopsy test to work like the other tests? It'll make your biopsies more sensitive if they're off PPI, because usually the density of H. pylori is higher. But that's a good question, McKenna. So this is kind of the algorithm for what to do for upper endoscopy as a diagnostic method for H. pylori infection. So gastric biopsies, you would get them if there's a bleeding peptic ulcer or other indication for gastric biopsy. If you see H. pylori, great, you have a diagnosis. But if there aren't H. pylori and you're quite concerned still, you then would get a urea breath test or stool antigen test to confirm whether or not they actually have H. pylori. If a biopsy urease test is available at your institution or at the institution that you practice at, this is preferred if there's no other indication for gastric biopsy because it's faster and a little bit more sensitive than histology is. So that's kind of the reason why you would get the biopsy urease test over the gastric biopsy. But this would be kind of per GI's recommendations, but as an explanation of like what the algorithm would be after you get those results. But really what we interact more with in the primary care side is probably the urea breath test or stool antigen test. So the urea breath test, I think we've all heard about. It's pretty sensitive and specific and can be performed in 15 to 20 minutes. Does this mean that urea breath test, stool antigen test is more sensitive than biopsy? Yes, in the correct circumstances, which I'll get to a little bit later, it is more sensitive than biopsy. But if you're going to need a biopsy anyway to rule out other sometimes H. pylori related complications, then you might need a biopsy anyway. So that's kind of the decision point. I don't know if I hadn't really seen someone do a urea breath test before, and this was a video. I don't know if the video is going to work, to be honest, but we'll see.
You are asked to come in after 4 hours of fasting and given a pill. And
oh no, it's buffering. Oh no, I broke it. Okay, well, so you get this pill. The pill is urea with the carb. Okay.
You are asked to come in after 4 hours of fasting and given a pill, and 30 minutes later you'll be asked to blow into a balloon and we can detect the bacteria. So if you have symptoms,
okay, I think we're just going to end it there. So
symptoms of abdominal bloating, discomfort, pain.
Stop playing. Okay, no. Basically, you swallow this pill. It has this urea ice.
You are asked to come in.
We're just gonna move on, and I'll explain it after. So, you swallow a pill. It's got a urea carbon isotope on the urea that's radioactive, basically, very slightly. Sorry, not radioactive. It's a labeled carbon isotope that we can detect on a machine. You swallow the pill, the H. pylori do their urease thing and break apart the urea, and they make the CO2 with the isotope, and you blow into a balloon, and the balloon attaches to a machine, and we measure the amount of isotope in the CO2 that you exhale. And so it's a really fast test that we can do for our patients. The stool antigen test is a similar sensitivity and specificity to the urea breath test, and it's more sensitive, as a completion of therapy test too. It can be predictive of eradication as early as 7 days after therapy. And then serologies, I feel like we've all ordered at some point, but really it's not recommended in low prevalence populations, such as in the US, because it's really not very sensitive or specific. But kind of the reason the case to get it would be in if you are really if you have it's a high negative predictive value. So if you're pretty sure that they do not have H. pylori, you can get an H. pylori serology just to confirm your assessment, I guess. So this is the algorithm for H. pylori. So if you don't have indications for invasive testing, you get the urea breath test or stool antigen test, because they are similarly sensitive and specific. If you test positive, great, you have a diagnosis. If you test negative, you have to kind of think about whether or not you trust that it's negative. If they've had any recent PPI, bismuth, or antibiotic use, any antibiotic, then you should repeat urea breath testing or stool antigen testing off PPI or bismuth therapy for at least a week or two. And that just makes these tests even more sensitive and specific. Yeah, so urea breath testing, because it needs a special equipment, isn't available at all clinics, but I think it's nice because, yeah, I think it's sometimes is a barrier to get patients to collect the stool sample. Other things to think about in H. pylori infection is some extra gastric manifestations. So it can cause iron deficiency anemia. It can cause vitamin B12 deficiency because inflammation in the stomach. The stomach is one of the pathways for B12 absorption. And there's some cases of actually H. pylori causing ITP just due to molecular mimicry. So I've seen some recommendations that ITP patients should get H. pylori testing. Okay, back to our patient. So she had an EGD, she had a non-perforated, non-bleeding, shallow, clean-based peptic ulcer, which was biopsied. There is no biopsy urease testing, and so they just did GI histology. You've been stalking her chart to try to figure out if she has H. pylori. And it showed chronic gastritis, but no organisms were seen. So what happened? You forgot to tell them to stop their PPI prior to their biopsy. So really, your PPI should be stopped within 1 to 2 weeks of testing for any testing, including biopsies, urea breath testing, and stool antigen testing to increase the sensitivity of those tests. Bismuth and antibiotic use within 4 weeks of testing can cause false negative results. Okay. So for her, because she had a gastric biopsy, but no H. pylori was seen, you decided to get a urea breath test, which was positive. So yay, you've diagnosed her with H. pylori. How do you want to treat her? We can just use the chat for this, probably. Like put in the chat what you think her therapy should be.
I can also launch a poll.
Okay.
I just got to click the button.
We can do a poll.
Makes me feel useful, Vicky.
Thanks, Nikki. So we've got clarithromycin, amoxicillin, PPI. We've got some bismuth with some antibiotics and PPIs. We've got your trusty Vanco, Cefi, metronidazole. And we have up to date.
I feel like even when I know the answer, I always double check it on up to date.
Mm-hmm.
Okay, well,
I do too.
Oops.
Great. Great. This is wonderful. Basically, I like didn't really understand like what antibiotics to treat H. pylori with outside of the sketchies from medical school. And so this is a good segue to talk about treatment. And so I think in medical school, I learned about triple therapy and quadruple therapy. So what does triple mean? Triple therapies colloquially generally refer to the clarithromycin-based therapies. And it's 3 different things. It's clarithromycin, another antibiotic, and a PPI. The other antibiotic is based on whether or not they have a penicillin allergy. So preferred is amoxicillin, but if they have a penicillin allergy, then metronidazole. So 3 things for 14 days. And you have to take these meds a few times a day. But this is actually, backing up, there's increasing amounts of macrolide resistance worldwide. And for this reason, in the US, we do not empirically treat with triple therapy. We do give empiric quadruple therapy, which is bismuth quadruple therapy. This is a combination of antibiotics that is not in the triple therapy. And it is tetracycline and metronidazole with bismuth and a PPI. So this is empiric quadruple therapy that we should be giving everyone in the US. There are exceptions if your kind of practice area has microbiology data for resistance of H. pylori, then you can give clarithromycin if there isn't very much macrolide resistance within the H. pylori in that population, but we do not routinely check for antibiotic resistance in H. pylori. So that data is not very available in the US. And so we do quadruple therapy empirically. But you're right, McKenna, that's a lot of pills for someone to take. Tetracycline 4 times a day, metronidazole 4 times a day. So she completed 14 days of this quad therapy. Her pain resolved. What do you do next? Another poll, Nikki, please. Your options are you monitor for symptoms post-treatment, and you retreat if her symptoms return. You just keep them on a PPI forever. You refer to GI just to follow up. You retest for H. pylori in 1 month, or they do nothing because they're already done with treatment. Great. I love it. We have to confirm that we've eradicated the H. pylori. So we do retest in 1 month. That retest is usually urea breath testing or fecal antigen testing, whatever is available. An upper endoscopy in some rare cases, such as when there is a large duodenal ulcer that they need to check for healing in, or if their H. pylori presented as gastric ulcers, they will often repeat EGDs because they usually will want to rebiopsy the site to check for any signs of malignancy after the H. pylori has resolved, just to confirm. And PPI should also be held for 1 to 2 weeks prior to this retest. But as McKenna kind of alluded to as well, a lot of people fail the initial attempt to eradicate H. pylori, about 20% of patients. There are some salvage therapy regimens that are available. And we can do endoscopy and try to culture the H. pylori after 2 courses of antibiotic treatment to try to figure out an antibiotic regimen that can help them eradicate H. pylori. But I think kind of one of the things to think about is how difficult it can be for a patient to remember to take antibiotics 4 times a day for 2 weeks. Not just remember, but also work it into their busy work or life schedules in general. And so this can be one unfortunate a reason why eradication can fail in our patients and puts them at risk for more resistant H. pylori. Unfortunately, McKenna, there aren't options for less pill burden because H. pylori is such a difficult organism to treat, just because it's really adapted well to our stomachs. Really, they need this like high dose of antibiotic in order to eradicate. There are some studies to see kind of what can be done to try to increase the rate of eradication. But probiotics have a small effect inconsistently on eradication, but they do reduce the adverse effects of all the antibiotics they're taking. There's a new class of stronger acid blockers than PPIs. They're potassium competitive acid blockers. The only one that I've seen really mentioned is vonoprazan. It's more potent and durable than PPIs, and they're studying its use in dual and triple therapies. This is not really available in most places yet, though, because it's a very, very new drug. Yeah, doxy-BID is one of kind of the salvage therapy regimens that people can be on. And as an alternative to tetracycline, but you still unfortunately need the like bismuth 4 times a day, and your metronidazole 3 to 4 times a day as well. And so I think overall pill burden is quite high still. So our patient had her urea breath test 1 month later, and that was negative. And she's going to tell her family member who's also having indigestion to maybe consider H. pylori testing in the future. So some take-home points for you all to consider. H. pylori is common and endemic to many parts of the world. It can manifest in a lot of different ways. If there are alarm features or you're worried at all, please refer to GI for an upper endoscopy. And make sure that you have eradicated and confirm that you've eradicated. You may need to treat for multiple rounds, unfortunately, just because I think treating H. pylori infection is really difficult. Thank you all.
There are some questions in the chat, Vicky. I'm not sure if you can see them.
Great. I can try to pull them up right now.
Vicky, can you remind me why bismuth is part of the regimen?
Yes. Oh gosh, I'm blanking now.
It's I can also look it up. I just couldn't remember.
I think it also kind of works to block some of the acid properties. I'm not sure. I can't remember now on the spot, but I can get you an answer on it.
No worries. I will look it up and throw it in the chat too.
Thank you so much.
There are also some questions like for patients that struggle with taking QID medications, which I think is like every human on the planet. Are there any like well-studied or well-validated alternative regimens with a lower pill burden? Or should you like really encourage people in their kind of standard treatment?
Yeah, I don't think that it's super well studied. There are kind of a lot of different salvage therapy regimens that have been studied that kind of have similar rates of eradication. Basically, kind of how I think about it is try kind of the best validated regimen, which is quad therapy. And if that fails, then you can try any of the salvage therapies as a second line. UpToDate has a table of all of the salvage therapies. I did not include it in this talk.
And then once someone has completed 2 weeks of treatment, if they're still having symptoms, like what should you do in those 4 weeks while you're waiting for the test of cure?
Yeah, that's a good question. I think kind of realistically, there are going to be patients who will continue on a PPI to try to treat their symptoms. But I think if it's not resolving, then it might be an indication to refer to GI to consider upper endoscopy for a more definitive diagnostic workup. And I think you should reconsider the differential for their dyspepsia. Maybe it's not just H. pylori.
And then we have lots of different explanations of why bismuth is effective. And Lauren, I'm not sure if you actually, she comments on, can I recommend Pepto-Bismol to treat H. pylori? I like this. And if you don't know, there's actually data that high doses of Pepto-Bismol can be used to prevent traveler's diarrhea. So I always recommend that to people.
I did not know
actually that. The studies are like really high doses, like over 10
how high,
like 10 tablets of the like tablet form of Pepto-Bismol a day, but it's actually kind of compelling data. So we tried it when we were in Indonesia, but it's a lot of Pepto-Bismol.
Yeah. Do you get any adverse effects from it besides like changing your DM's color?
Turning them black. Oh, Pepto-Bismol has salicylate. Lots of interesting Pepto-Bismol facts. Where's Gina when we need her about over-the-counter medications? And then McKenna asks one final question. Even if you eradicate H. pylori, can they still have some of the later complications that you showed, or does the damage heal itself?
It's a good question. I don't think that this is super well studied. Unfortunately, because H. pylori is this chronic inflammatory state, they are at risk. And it kind of depends on how long they've had the H. pylori for. And it's hard to study that because we don't really fully understand, or it's hard for us to figure out when they would have contracted H. pylori because it's kind of this insidious infection. I think that definitely if someone has had H. pylori and now they're having some alarm features, even after eradication, then I would consider consulting GI, especially for alarm features. So like the weight loss, dysphagia, things like that.
Vicky, this was awesome. I really appreciate it.
Yeah, sorry for all the technical difficulties earlier.
Interns, you are off to Intern Core Conference for the final session. I just put the link in the chat. But it's also in the email that I sent yesterday. And I'm sure Vicky will stick around to answer some questions, and then maybe a 7-minute break, 10:53, and we can get Joe Kirsch teaching us about some primary care topics.
Vicky, your technical issues were hardly noticeable. It was totally fine.
Thank you. And I also thank McKenna, who was my plant in the audience, for asking all the leading questions.
I wasn't actually a plant. I was just interested.
Even if it were true, don't reveal your secrets. The magic is only magic if it seems like it's magic.